So I'm Lauren Brown. I'm one of the genetic counselors that works at the University of Washington with Dr. Bird that you just heard from and Dr. Distad that you heard from earlier this morning. Oh, good. Yeah, and I'm going to be talking about A, why I have the coolest job at the Med Center, and B, how it applies to you and your families and how we could potentially work together. So, coolest job because I get to be like Sherlock Holmes every day, come to work and put on my detective hat and help families try to figure out what is the type of CMT in our family. I get to answer questions like, why is it just me? All these other families have generation after generation, and they can look back and they knew they were at risk for this condition, but why am I the first one in my family to have this condition? Or I get to answer questions like, are my kids at risk for this condition? Are my sons at risk? Are my daughters at risk? When would I expect symptoms in them if they were going to have this or develop a type of CMT? I get to answer questions like, why me? Why me? Why did my sibling get off the hook, and why did I get hit with this? So I have a very cool job. And then after I work with families to figure out what type of CMT they have, I get to be a resource to those families to plug them into events like this. I told a number of people, maybe some of you are out here right now, about today's event. There's people that will say, I've never met someone else with CMT, and I'm the first one to say, here's a community of people that you can go start to get to know and hear what's happening with them. I get to work with families maybe that don't have symptoms yet. We're in the next generation where somebody's in their 20s and is in a family where it starts in the 40s, but they're making decisions about having children. And so they come to me to try to talk through, what would this mean to have a child that's similarly affected? Or what would it be like if my child was more severely affected than I am? And start to make decisions about how that plays into their family planning. There we go. So people come asking all sorts of questions, and I'm going to kind of walk through what a genetic counseling visit looks like, what some of our goals are when we're sitting down with folks. And just logistics. What does testing look like these days? How much does it cost? What are my next steps if I don't know my type, or even if I do know my type? So a little genetics 101 that you've been hearing in different ways from both Dr. Bird and Dr. Distad. But the real takeaway from my cartoon is your whole body's made of cells. Inside of your cells are your genetic material, or your DNA, and it's written out in these first it's housed on these structures called chromosomes, and Dr. Bird showed you how back in 1980 that's all we could figure out, what chromosome was holding a certain genetic condition. But since then we've been able to uncover a lot more information about the individual genes. We think you have about 20,000 genes in your body, and right now we've learned maybe about 92 or so of them have some role in neuropathy. There's certainly going to be more discovered, but right now our understanding is surrounding those 92 or so genes. And so when the lab is doing testing for a family, it's usually on a blood sample or sometimes a saliva sample these days. But what the testing is actually doing is they're zooming in on these genes, and they're reading through the genes letter by letter, like reading in an instruction book, looking for spelling mistakes. And it's those spelling mistakes that it's then our job to try to interpret, is this the answer for your family? Is this what's causing the Charcot-Marie-Tooth? So when folks come in, and most of my talk is targeted to folks that don't know their type yet, but when folks come in, one of our first things is trying to figure out, why are you here in our genetics clinic? What is your goal? We pretty quickly have to determine, is someone's goal to change treatment? We're very upfront that right now, just because I can find your CMT subtype, I'm not going to recommend any changes in treatment. Your doctors aren't going to put you on a different medication or treat your symptoms differently just because we know the type. And that fact often makes it hard to argue to insurance companies that some of this testing is important. Insurance always comes back to, how does this change medical management? It's hard for me to justify to an insurance, even though I believe it very strongly, that there's value in knowing what type is in your family, and there's value to having a name for the condition. Dr. Bird and I were just talking about this yesterday, but when there's a name, people want to know it, even if it's just CMT is helpful, but even more specifically, knowing CMT type 2B, type 1A, being able to turn and say, who's researching the type in my family? What clinical studies are happening related to the type of CMT in my family? Where should I put my money if I'm donating to a research cause? I want to donate it to the one that's learning about what's happening in my family. More than that, I think your providers are able to be a lot more specific about prognosis when we know the type in your family. So if somebody comes in and just wants to know what is this going to look like in 30 years, I'm able to be a lot more specific if I know what's causing it for them. Sometimes their test result will come back with something very common like 1A, and then I have a ton of information about what other health problems to expect, to be thinking about, do you have sleep apnea, do you have restless legs, these different things that have been reported and I know about from the literature. Versus sometimes I'll get a family with a new gene that's only been described in maybe 1 or 2 other individuals, and we have a lot less information to draw from, but at least they're able to stay on top of as new information comes out, they know what to be looking for. So at the visit, we're discussing goals, We're gathering personal and family health history, and I'll get into this, but really we're looking for clues as to, is this something that's running generation to generation? Are you the first one in your family? Is it a family like Dr. Bird showed, where it's generation to generation, but it's never a male to male that makes us think it could be X-linked? So there's different clues we'll find. We're usually doing a brief neurological exam, very similar to something you've done with any of your other neurologists. One benefit of meeting with a genetic counselor, at least these days in 2018, is we can often spare you the nerve study. So woohoo, for your future relatives that don't have to go through that. And we'll go through pros and cons. Testing is not yet perfect, and even a normal test does not mean your family doesn't have a genetic cause of CMT. Just like these families Dr. Bird has been working with, sometimes it will still continue to take us decades to figure out what's causing it for a specific family. Some of the clues we use, Dr. Distad went through this for you, but one of the clues, if we have it, is that needle study, trying to see, is it really your myelin sheath that's affected? Is that what's showing problems? Or is it the axon that seems to be affected? And for me, that's important information going into a conversation with a family, because for a family where it's the myelin affected, I can be more optimistic that we'll find an answer. For a lot of these families with a demyelinating neuropathy, we're pretty good in 2018 at finding the genetic subtype. One of the reasons that Dr. Bird's current research is so targeted to the families with this axonal problem is that's been a lot harder for us to figure out what the genetic basis is for those families. And so for somebody where we're doing an EMG and I'm seeing that it's the axon that primarily has problems, I'm upfront and warning them that we could find an answer. Probably about 30% of families we find an answer right now, but that leaves a majority of families that even in 2018, we're not yet smart enough to figure out what's going on. We're using family history as a clue. We're using what age were you when you first started to show symptoms. We're asking things like, are men more affected than women? And then looking for other health problems that could be clues as to what specific type is happening in the family. This is a similar picture to things you've already seen this morning, but trying to go into how do we, historically, how have we named these diseases? And the first way we break it down is into how is the condition inherited in the family. And so if it's inherited from generation to generation to generation, we call that an autosomal dominant pattern, where if somebody has it, there's that 50% chance for their kids, boys or girls. And autosomal dominant, we break down farther to what did we see on that EMG? Was it problems with the myelin or was it problems with the axon? And so that's where you'll hear the first part, that CMT type 1 or CMT type 2. And then Dr. Bird was showing you that as they discovered those different genes, they'd label them A, B, C, and go down from there. With 92 genes out there, this is getting not quite specific enough and not quite clear enough when we're talking. So we're getting towards more describing it as the gene-related neuropathy. So PMP22-related neuropathy, MPZ-related neuropathy is probably going to be where it heads. It's also, there's a lot of overlap once we get outside of autosomal dominant. Many of these genes can cause either a demyelinating neuropathy or an axonal neuropathy, or a mixed presentation when we're doing those studies. So that's not as clear to break it down. But you can see CMT4 is describing families with that recessive pattern where mom and dad were carriers and they both passed it on, and that's when the individual has the condition in that double dose, or X-linked, which is that family Dr. Bird was just showing. 5 or so years ago, I would have put a lot of weight into this chart in deciding what test to order for a family, because genetic testing used to be fairly expensive. I'm going to show you now why most of our families don't pay anything. But used to be fairly expensive, so we used to put a lot of time and thought into which genes should we test for this family. Does it look autosomal dominant? Was it the myelin affected? And we'd order just a handful of genes related to what we were seeing. These days, we're going most of the time a lot bigger. So first thing, and something I was talking about with folks at my table when I'm deciding what test to order, if I already know the type of CMT in your family, it doesn't change. If you have type 1A and you're wondering, does my child have this, I only need to test them for 1A. If it's 1A in the family, it's going to be 1A in other relatives. If it's 2B, it's going to be 2B in other relatives. Sure, there's some rare exceptions of families that have two types, but that's not you. So if I know what's in your family, that's what I'm going to test for. If I don't know what's in your family, I'm going to go a lot bigger. What we've been doing lately, because it's been offered for no charge, is this test at a lab down in California called Invitae. It's a company that does clinical testing, so it's not research testing, but right now the test is being covered by a pharmaceutical company who has a motivation to identify one really rare cause, down here TTR, one very rare genetic cause of neuropathy that they've created a drug for. And so their vested interest is to identify as many people as possible with this one very rare cause, which usually has a number of other health problems available, isn't usually the highest thing on our list for our patients. But in order to entice me to look for that mutation, they offer this 72 gene panel so we can go a lot broader, which has made it possible for us to identify the cause in a lot more families than we previously were able to when we did that one gene at a time approach. This testing can be done on blood or saliva. It usually only takes about 3 weeks to come back. Right now it's offered for no charge, but even when people are paying out of pocket, when this drug company goes away, it's only a couple $100s. So it's nowhere near what genetic testing used to cost when it was several thousand per gene. So even though I can't convince your insurance necessarily to always pay for this type of genetic testing, for most families it's becoming more within reach to get this information. For a number of families, particularly those with this axonal type of neuropathy, where maybe I do that 72 gene test and I don't come back with a clear answer, we do have additional options. It kind of gets blurry between, are we doing clinical testing or research testing? There's a lot of overlap by the time we're getting to this bigger size test. So this next test I'm thinking about is called an exome or a genome, depending on how I order it. But instead of zooming in on these 70 to 92 genes that I know have some basis in neuropathy, I'm looking at 20,000 genes. I'm looking at your whole genetic library to say, could I find something that just hasn't been described yet? This is not right now a very helpful test when I just have one affected person in a family. Because when I look at 20,000 genes, or at least when the lab does, they're going to find so many changes, so many differences. We're not all identical twins. And it's the lab and as clinicians, our job to try to decide, is this change important? And if I'm studying a new gene, how am I to know if this change in gene XXX has anything to do with neuropathy? But if I have a large family, like some of the families Dr. Bird was showing, it lets me do some of these bigger tests, because all of a sudden I can trace and say, is this running with the disease in the family, and get a better sense for, is this really the cause or not? Don't think I've ever gotten insurance to pay for this yet. I don't hate them for that. It's probably reasonable. We've had a couple folks self-pay for this testing, but again, most of them have been done on a research basis for those really compelling family histories. So that's what an exome looks like to me. You're reading through all these books, and half of them are written in Japanese, and you don't speak Japanese, so you don't know what a spelling mistake means just yet. When I get results back, either from that exome or from those 70 to 90 gene panels, there's a couple different results I could get back. So I could get back a positive result, meaning slam dunk, I found the answer for your family. And now we can talk about, what has this looked like for other individuals? What does this mean for your relatives? Who else in the family has the same condition? Who else in your family is at risk for the same condition? What does it mean for family planning as you're making decisions about having babies? We can get you plugged in with websites like clinicaltrials.gov that you all were scribbling down frantically this morning, where you can go on that website and type in, okay, now I know I have CMT2C. Who's studying that? What are they studying? Are they just collecting information? Or are they trialing medications? And you can be a more proactive member in your own healthcare. With positive results, again, right now we're not changing treatment. There's some things coming down the pike that Dr. Distad was talking about, maybe even for 1A. There was a phase 3 trial that everyone was very excited about online. And so I think it all kind of starts with knowing what is your type that we can get excited about some of these research options. So obviously that's my goal, to get families clear answers. Still, a significant proportion of families, we come back and it's just all normal. And so most of the times for those families, we're saying, we still think you have a hereditary neuropathy. Something about your age or your symptoms or your family history makes us continue to be suspicious for something genetic. And usually we're following those families every 2-3 years. As genetic testing changes, we check back in and offer new tests. The third thing that can come back that we talk a lot about in clinic, and I don't know if any of you have had the fortune of getting one of these results, but a variant of uncertain significance. So they read through these genes and they find a change, but the lab doesn't know what to make of that change. They don't know if this is what's causing the condition for you or if it's just a harmless change that the lab has not seen before. Sometimes there's things that make us suspicious about some of these changes, and we'll test people in your family, and we'll see, did this come from mom's side or dad's side? Does my cousin Joe that has this similar condition also carry this change? Most of the time, they're a bunch of harmless changes that we don't get too excited about. And then we see folks again in 2 to 3 years to check back in. I think I still have a little time for questions. If people want to ask them now, I'll also be around at the end of the day, and then put my contact information up there as well. You're welcome.
I have a question about our children. My daughter has type 1A and had a positive genetic test, and our son presents with CMT1A, had his genetic test, and it was negative.
I can't answer that right now. Sounds like a stumper that I'd need some more time with. Doesn't make sense. I'll be around. Oh, yeah.
Is testing done like blind testing? Like, is your insurance going to find out that now you have it, or is there a way to do testing that doesn't include your name?
That's a great question. So there's not a great way to do anonymous testing. So there's always the risk that your insurance will see this in your medical records. We feel fairly reassured, at least right now in 2018, about health insurance. There was a law passed back in 2008 called the Genetic Information Non-Discrimination Act, passed under a Republican president, so whatever you'll make of that. But the idea being health insurance and employers can't discriminate against you just because you have a genetic condition or you're at risk for a genetic condition. The same laws don't cover life insurance and long-term care insurance. And so especially if I'm sitting down with somebody's 20-year-old child that does not yet have symptoms but wants to do a test to figure out if they're going to develop symptoms in their lifetime, that's something we spend a lot of time thinking about is it worthwhile to go get some of those life insurance plans before you move forward with the actual blood test so that you can get those and won't be discriminated against. Yeah, in the back. Yeah. I'm not the best person. Probably our historical guru is going to be the best person to ask that of. But certainly we know that if we track these genetic changes back far enough in a family, most of them started somewhere. So someone was the first person in their family to have even these autosomal dominant types. When that happens, we call it a de novo mutation, meaning a new mutation that just happened in that egg cell or that sperm cell that created that person, but it's genetic after that. If it's in every cell of my body, 50% of my children would get it, even though I was the first one in my family. But I don't know too much more than that about the studies that have been done. Yeah.
Let's go right here.
Does it happen worldwide, or is it
just in certain areas around the world?
Yeah, fantastic question. Worldwide, there are certain mutations, very specific spelling mistakes that we see more commonly in certain ethnic groups. So one of the questions we'll often ask when we first sit down with a family is, what countries do you think your mom was from? What countries do you think your dad's family was from? Because it'll give us, is there a higher level of suspicion for very certain things?
Great question.
Nope. I thought I saw somebody at this table. Nope, back there.
Here we go.
So you said it's more prominent in certain countries. Is there access to that? Like what countries it is? Is there like a post anywhere where you can see where it's more prominent in certain countries, or?
And I wouldn't say the disease is more prominent in certain countries, but there are specific spelling mistakes that we know are more likely to pop up. There are databases that are public databases, but not necessarily designed for folks that aren't in healthcare, that you can go and see how common are certain mutations. Yeah.